Hello, my name is Stephanie Youssef, and along with Dr. Nissa Farrell, we'll be presenting this skull-based oncology case series on esthesioneuroblastoma, management of the N0 neck. A 59-year-old male presented to clinic with years of right-sided nasal obstruction, persistent thick right-sided nasal drainage, recurrent epistaxis, and headaches. The patient was a former 15-pack-year smoker, but had no other significant past medical history. On exam, extraocular movements were intact, there was no proptosis, facial sensation and movement were intact, and he had no palpable cervical lymphadenopathy. Rigid nasal endoscopy revealed a large red pulsatile mass visible in the right choana with extension into the inferior meatus and surrounding mucopurulence. Further imaging, including a CT and MRI, were obtained. MRI of the face showed a 4 cm heterogeneously enhancing mass centered in the right ethmoid sinus, extending into the posterior nasopharynx and up to the anterior skull base with erosion of the right cribriform. There was post-obstructive opacification of the right-sided paranasal sinuses, as well as the right mastoid air cells. No evidence of intracranial involvement or other osseous destruction was seen. The patient subsequently underwent biopsy of the nasopharyngeal mass, pathology of which showed atypical cells arranged in nests with foci of necrosis, as well as evidence of lymphovascular invasion. These cells stained positive for synaptophysin, chromogranin, calretinin, and S100 consistent with esthesioneuroblastoma, also known as olfactory neuroblastoma. It's a rare malignant tumor of the sinonasal cavity thought to arise from olfactory epithelium. The Hyams grade is a specific pathologic classification system used for esthesioneuroblastoma to score tumor differentiation. Tumors are graded from 1 to 4 based on pathologic features such as mitotic activity and necrosis, with grades 1 to 2 representing low-grade lesions and 3 to 4 representing high-grade lesions. In this case, the patient's tumor was classified as a Hyams grade 3. A PET scan was then obtained demonstrating the patient's right nasal soft tissue density with moderate FDG avidity. There was no convincing evidence of distant metastasis, but it did show prominent bilateral cervical lymph nodes with minimal FDG avidity. Further investigation with neck ultrasound revealed normal appearing lymph nodes within the bilateral neck with no obvious target for needle biopsy. The most widely used staging approach to esthesioneuroblastoma is the Kadish clinical staging system. It was initially proposed as stages A through C, classifying the extent of the primary tumor, with stage D added later as a modification to stratify regional metastasis. In this case, the patient was classified as a Kadish stage C, given his anterior skull base involvement and the lack of nodal or distant metastasis. Most tumors present solely as local Kadish A through C disease, as the incidence of neck disease at the time of initial diagnosis is between 5 and 12%. However, esthesioneuroblastoma has a characteristic predilection for delayed cervical lymph node metastasis, with most regional lymph node disease arising at least 6 months after primary treatment, and eventually occurring in up to 25% of patients overall. Some studies have shown the development of lymph node disease over 20 years after primary treatment. Notably, many studies demonstrate that the development of neck metastases with esthesioneuroblastoma constitutes the most significant predictor of poor survival outcomes for patients. A systematic review of 13 articles and 269 patients demonstrated that the development of neck disease decreased overall survival from 60% to 32%, though no time frame was reported for this survival statistic. All patients with neck recurrence died of their disease in this study. Another multi-center retrospective case series of 113 patients showed that 5-year overall survival decreased from 91% to 73% if patients developed delayed neck disease. For positive neck disease present at diagnosis, or Kadish stage D, the recommended treatment generally includes the addition of a neck dissection with adjuvant neck radiation. Conversely, the optimal approach to the clinically negative neck is still to be determined due to the rarity of the disease, the lack of large randomized trials, and the high proportion of late neck metastases which can take several years to present. The propensity for delayed neck disease and its implications on survival poses a dilemma with whether or not there is a role for elective neck treatment in the clinically negative neck. Part of this dilemma stems from the difficulty predicting where potential nodal disease may present. Of the patients who develop delayed neck disease, the most commonly noted site of occurrence is ipsilateral neck level 2, but metastases in all levels of the neck, contralateral and bilateral, are well documented. In fact, one retrospective study of 80 patients noted that approximately half of delayed neck disease presented bilaterally. Furthermore, a volumetric tumor study of esthesioneuroblastoma showed that contralateral neck disease was unrelated to the degree of laterality of the primary tumor. This may be in part due to the midline nature of the disease. These factors give rise to significant controversy surrounding the appropriate laterality of elective neck treatment if given. Fundamentally, the underlying mechanism of delayed nodal disease in esthesioneuroblastoma is not well defined. In a retrospective study of 109 patients, 61% of those with delayed neck disease had no evidence of recurrence at the primary site at the time of detection of neck metastases. Therefore, it's been suggested that there may be occult metastases present at the time of initial tumor presentation. If delayed nodal disease stems from occult metastases present at diagnosis, then intuitively, elective neck treatment may be beneficial. However, a multi-center retrospective study of 113 patients found that positive surgical margins at the primary resection were associated with a higher risk of neck recurrence. This suggests that local tumor recurrence and subsequent regional spread may also play a role. Though the development of delayed neck disease in esthesioneuroblastoma can be unpredictable, certain factors have been used to identify patients at increased risk. One such attempt has been made utilizing Kadish staging. Though multiple studies have shown higher Kadish stage to be a poor prognostic factor for overall survival, the relationship to the development of neck disease is unclear. One smaller retrospective study did not find an association between Kadish stage and the development of neck disease. In fact, after 10 years, approximately 40% of Kadish A and B developed neck disease, while only 28% of stage C developed neck disease. It's important to note, however, that this was a very small study. A systematic review did attempt to answer the question of whether Kadish staging can predict the development of neck disease. After reviewing 13 studies with a total of 310 patients, there was a strong association between Kadish B or C staging and neck disease, with approximately 21% of patients with Kadish C staging developing neck disease. While the systematic review certainly implies that Kadish C may be predictive, there is a controversy regarding Kadish stage C, as some argue that it represents an overly broad category of patients. As stated before, Kadish C is defined as an extension beyond the paranasal sinuses, with involvement of the cribriform, lamina, orbit, skull base, or intracranial. As such, this encompasses an extremely broad category ranging from cases like ours, with only cribriform erosion, as well as tumors with extensive intracranial or orbital invasion. One proposed modification to Kadish C suggests delineating by dural involvement status. A retrospective case series of 61 patients found a significant association between dural involvement, nodal disease, and poor overall survival. Specifically, patients with dural involvement exhibited over a twofold elevation in the incidence of neck metastases. Of patients with neck disease, those with dural involvement were almost 5 times as likely to have bilateral nodal involvement than those without. In the setting of elective neck treatment, these results suggest that identifying risk of delayed nodal disease by dural invasion status, rather than Kadish stage alone, may be more helpful. Unlike Kadish staging, the Hyams grading system appears to be more predictive of the development of neck disease. In a meta-analysis of 525 patients, rates of neck metastasis were higher in high-grade tumors, Hyams 3 and 4, as compared to low-grade tumors, Hyams 1 and 2. Even for those at high risk of developing neck disease, the optimal treatment approach is uncertain. A suggested benefit to elective neck treatment relates to improved regional control, but introduces the morbidity associated with surgery and/or radiation to the neck. A systematic review and meta-analysis of 489 esthesioneuroblastoma patients with clinically negative necks assessed the impact of elective neck irradiation in terms of regional disease control and survival. A pooled odds ratio from 9 studies included found an 88% lower odds for regional nodal relapse with elective nodal irradiation compared to observation. 2 of the included studies, totaling 265 patients, compared the overall survival and distant metastasis-free survival between the 2 treatments. The pooled estimate shows no difference in 5-year overall survival or distant metastasis-free survival, though there were limitations to these studies, primarily due to selection bias and the retrospective nature of the cohorts analyzed. Rather than performing elective neck irradiation, some have suggested observation with salvage treatment if neck disease occurs. This allows for targeted treatment of clinically apparent disease while minimizing the morbidity of elective neck therapy. A small systematic review of only 45 patients with delayed neck metastases assessed the efficacy of salvage neck therapy. 68% of the included patients failed salvage therapy, defined as disease recurrence within 1 year. When stratified by salvage treatment modality, combined surgery and radiotherapy increased the rate of successful neck salvage over either surgery or radiation alone. A later study examined a retrospective cohort of 17 patients with delayed neck disease who underwent salvage therapy. 4-year cervical lymph node recurrence-free survival was 70%. 5-year overall survival following salvage treatment for the delayed cervical lymph node metastasis was 39%. It's important to note that this was also a very small study. In July 2019, the American Rhinologic Society published an international consensus statement of endoscopic skull-base surgery. This publication resulted from a joint effort from both otolaryngologists and neurosurgeons in skull-base surgery reviewing the literature. With regard to management of the clinically negative neck in esthesioneuroblastoma, this examination of the literature produced a grade C aggregate grade of evidence based on the studies appraised. Key points summarized from the reviewed literature showed that delayed neck metastases in esthesioneuroblastoma can occur over 10 years following primary treatment and is associated with worse overall survival and disease-free survival. This publication acknowledged that benefit from elective treatment of the clinically negative neck is unknown, though elective irradiation shows improved regional control in small studies. Given that delayed regional involvement in the neck is common, their proposed benefit-harm assessment recommended consideration of elective neck treatment in patients with high Hyams grade lesions and Cadiz stage C involving more than dura for prevention of regional recurrence. Long-term surveillance of the neck was recommended. Overall, evidence to support the optimal treatment of the clinically negative neck is limited, as most of the evidence available relies on small observational studies. Due to the rarity of the disease, no prospective clinical trials exist that directly compare elective neck treatment to observation with salvage therapy for those who do relapse. Further studies are needed to investigate the optimal approach to the laterality of any potential elective neck intervention, as well as if chemotherapy or immunotherapy can play a role in elective or salvage treatment. In addition to the suggested limitations of the Cadiz staging system, there is limited data on whether specific genetic alterations or pathologic features such as the lymphovascular invasion seen in this case should influence therapeutic decisions in managing the neck. Ultimately, after multidisciplinary tumor board discussion, our patient underwent combined endoscopic and open craniofacial resection and reconstruction with pericranial flap, tensor fascial autograft, and fat graft. Postoperatively, he underwent adjuvant radiation to the primary site as well as elective radiation to the bilateral necks. He is currently 1 year post-primary treatment with no evidence of disease recurrence.